In the meantime, I'm going to get us started on our next panel. So I'm going to invite up our panelists, Nima Maharaj, Dr. Andrea, Susan Miller, Sarah, and Dr. Natoya. Okay, so for the purposes of today, our mic doesn't work, it's out of battery, so I'm going to ask you to step up to one of these two mics and we'll just do a little bit of switching around if we need to. So today is our panel. It's focused a little bit more on understanding the cancer care system, and that's where we're going to begin. So I'm going to ask Sarah Coney. I have some questions for you to start us off. So my main question for you is, can you help us understand how cancer services are structured and coordinated across Ontario, from prevention and screening to treatment and survivorship?
Yeah, absolutely. So I will start with saying, I mentioned earlier this morning about how we are one region of 13 in the province of Ontario. And so we're really fortunate actually to have a very well-run Ontario Health, CancerCare Ontario program. And CancerCare Ontario as an organization, institution, has been around for quite a long time. I think I had looked it up yesterday, since like 1997. So it's been around as an organization to help us focus on the quality of care that we would need to deliver for cancer in our province. And because it has a long history, it's been doing this work so long that it's very clearly set out about how we should go about every phase of treatment. And that starts right with screening. So the screening programs we talked about this morning are actually all run at a provincial level. We don't administer them here in the region ourselves. They all come from the province as a large organized program. And so it doesn't matter if you live here or Toronto or in Thunder Bay, you're accessing cancer screening the same way, no matter where you live. So that's the first part of the organization, which is unique. The second steps for after you've done screening is where your region comes into play. And there are specific programs that are offered in your region that will follow up on the next steps of diagnosis. So as I said, we are one of 13 regional cancer programs. And so the cancer center down the street is the hub of the cancer services for our region. And then all the other hospitals are kind of like the spokes. So we do have responsibility, for example, for the oversight of cancer surgery, again, at the cancer center, even though it's being delivered, let's say, at Cambridge Memorial Hospital or at Wellington General Hospital. We have oversight for the quality of the care being provided at every hospital in the region through the regional cancer program. So that's what I mean when I say a hub and spoke. And then we already went over this morning, but we do have chemotherapy, as I said, at the cancer center here, but in Cambridge, Guelph, Fergus, Mount Forest, and the radiation services are here. What I will say is that there are some cancers that are specialized enough that we will not treat them in our region. So when you get into fairly specialized and more rare cancers, those sometimes require a bringing together of the specialists into a center of excellence. So an example of that is not all head and neck cancers are treated in our region. We don't necessarily have surgeons who specialize in some forms of head and neck cancer. And so patients will actually go outside our region for some types of cancer treatment. So we will know that though when the patient's referred to us. So the referral may still come from your family doctor or a surgeon you've seen to the cancer center, and then we will help ensure that it gets out to where it needs to go if it's not something that we treat locally. The other thing I'll just point out is a bit different is childhood cancer. So we've talked a lot about the cancer that we experience as adults, but we know children also can develop cancer. And the cancers in childhood are quite different in some ways than the cancers you see in adults. And so again, you need really specialized care to be able to have expertise in that area of treatment. So the centers of excellence for childhood cancers are, again, mostly outside the region, but then we've become a spoke for that. So if Hamilton is a hub or Princess Margaret Hospital Toronto is a hub, we are a spoke where if a child does need chemotherapy, they can have chemotherapy down at the Ren Hospital, but it's through a different pathway and through a different organization. So that one's called POGO, the Pediatric Oncology Group of Ontario. And so that's a different setup than what we might see for our adult cancers. So that's like very roughly how we're set up in this region. And we're very connected to every hospital. We don't work independently of each other. And our physicians, like our medical oncologists, have very close connections to all the specialists throughout the region. It doesn't matter where the patient lives, they can make those connections to those specialists in the other cities and regions. And so we're not isolated by each of our cities.
Right.
Yeah.
Thank you. And you actually answered a little bit of my next question, so I'll move to the follow-up. Could you tell us a little bit more about the specifics of the Waterloo Regional Health Network Cancer Center and the role it plays in supporting patients with local clinics, primary care providers, and the hospitals, those folks that you talked about?
Yeah. So we're called the Ren Cancer Center down at the end of the street here at the hospital there. But that is just one piece of the bigger picture, which is why we keep referring ourselves to the Waterloo Wellington Regional Cancer Program, because each of the hospitals are linked to us. In terms of primary care, Judy mentioned this morning, that we actually have within our regional cancer program leads for all these different specialties. So for example, Dr. Neil Nyack is a family physician, but he actually works in the cancer center to help us ensure that all primary care family physicians in the region are getting information about cancer screening and any changes coming down. So for example, last year, we know that the breast screening program changed its age range for screening, and it went from 50 to 74 to having down to the age of 40 now, you can start to screen. That was a big change for the region, so we took responsibility as the regional cancer program through Dr. Neil Nyack and people like Barb you met this morning, and we have a cancer screening lead, Dr. Mansuela. That group together went out and did all the education for the primary care, for the family physician. So that's another example where we're linked and coordinated as the regional cancer program for whether it's screening, surgery. We have a lead for colonoscopy. We have a lead for endoscopy. So we coordinate that all through that group that we work together on very closely to make sure that everybody has the information they need. And then CancerCare Ontario sends all that information through our office. So we get lots of information coming from the province, and then it's our responsibility to get it out in the region.
Wow, it's a lot of responsibility. Thank you so much for sharing, Sarah.
Yeah.
Next I'll ask Dr. Andrea to take the stand as well. We'll move a little bit into early detection and why that matters. So Dr. Andrea, and forgive me, is it your last name Molchowski?
Yeah, Molkowski.
Molkowski,
Yeah.
Thank you. Dr. Molkowski, from your experience as a medical oncologist, why is early detection so critical when it comes to cancer survival?
Basically, the smaller a cancer is when you detect it, the easier it will be to cure you of that cancer. And that's the whole point of the screening programs that we have in Ontario. So if we find a breast cancer before you can feel a lump, that's probably less than 2 centimeters in size. By the time you can feel something in your breast, it's at least 2 centimeters in size, and that automatically is the next T stage of the cancer, which I'll talk about in the next question. So that's why mammography is so important. Similarly with lung cancer, the lung cancer screening program is meant to detect things that are too small to cause a cough or any other shortness of breath, because it can be found very early and cut out. colon cancer screening is looking for signs of very, very minute bleeding from the tumor in your colon. So that's why the FIT testing is important, because we don't want you to come to your family doctor saying, I'm having bloody bowel movements, I can see bright red blood in my stool. We'd rather find it earlier when that little polyp or little cancer is still very much an early stage. And that goes to finding symptoms as early as possible as well. So I can't tell you how many times I have people that say, well, I had some bleeding when I went to the bathroom, but I think it's just hemorrhoids. I see that a lot in our colon cancer and rectal cancer patients where, it was all chalked up to hemorrhoids. Nothing was ever done about it. And they should have had a colonoscopy, because at that point, when you have bleeding from your rectum, it is not a screening colonoscopy that you need, but an actual diagnostic colonoscopy that you need to look for cancer. There's other, similarly with breast lumps, there's never a reason not to go looking for why you might have a breast lump. I've had a lot of patients that presented when they were pregnant or breastfeeding with a lump, and it was just unfortunately chalked up to, mastitis or something, and treated with antibiotics and never went away, and then that became a larger cancer. So listening to what you feel is right, and having advocates in your family doctor is really important, and in your family too. There's one more point, is that nowadays a lot of people are getting screening colonoscopies, and some people don't realize that colon cancer arises from polyps that originally start out as precancers. So they start out as dysplastic polyps. Dysplasia just means the cells look abnormal but are not cancerous. So sometimes people may not know that their mother or brother had a colonoscopy that found a dysplastic polyp. Now, because that dysplastic polyp was removed by the gastroenterologist or surgeon, that patient avoided getting colon cancer. But sometimes family members need to realize that if their direct family member had one of those dysplastic polyps, they are eligible for high-risk screening with colonoscopy. You should not be getting just FIT testing, but they need colonoscopies if they find that their family members had dysplastic polyps. So just an important point to mention as well.
Yeah, right. And I know you spoke a little bit about early signs of people miss and the difference that early detection makes, but what would you say to somebody that is afraid of screening or diagnosis?
It's understandable. I think someone this morning, if you don't do the screening, then you don't have the problem, right? So you can just go on with your life and not have to worry about having cancer. But, it is a big regret, I think, of people when they do have cancer that maybe didn't go through with the screening, is that, maybe they would have chosen to do so if they had known what would have happened. And that's something I think every person individually has to come to terms with, that screening does not mean that you're going to have a higher likelihood of cancer. It just means that if you were to develop cancer and it's caught by screening, you have a higher chance of getting rid of the cancer, having it cut out, and being cured of your cancer.
Okay. Thank you. And many people hear the word stage when they're diagnosed, but may not fully understand it. So can you explain a little bit about what cancer staging means and how it influences treatment decisions?
So cancer staging has been developed over many years, and for each cancer, we have a way to classify the anatomy of the cancer. So we start with the size of the cancer in most cases. How big is this cancer? And it's on a relative scale. So in breast cancer, we go up to 2 centimeters is sort of the lowest stage, and then greater than 5 centimeters of the actual mass is sort of the more advanced T stage. In colon cancer, it depends on the depth of invasion of the cancer into the wall of the colon. So that determines the anatomic stage. In lung cancer, the size also is part of the staging, etc. Now, part of the staging also means where will the cancer travel to, and that's part of the staging. So every body site in your body drains into lymph nodes. So when we think about breast cancer or breast tissue, our tissues are constantly draining through lymph very slowly, but when you get sick, you notice because you have, enlarged lymph nodes, because the white cells in those lymph nodes are fighting the virus and enlarging. But the same thing happens with cancer. Sometimes cancer, unfortunately, tracks along those lymph channels. So for breast cancer, we talk about lymph nodes under the arm here in your axilla. That's part of the staging as well. For lung cancer, all the lymph nodes are behind your breastbone in the middle of your chest, and that's where the lung cancers travel along. In a head and neck cancer, it travels to lymph nodes you can see in your head and neck along the sides. And then your colon and prostate and cervix, it's all these lymph nodes that are in your pelvis. So a lot of them are hidden, you can't necessarily see them, but they're taken out at the time of surgery to help us understand what the staging is. The final aspect of staging is unfortunately when the cancer cells have traveled beyond the lymph nodes and they've traveled to other organs through your blood or along lymph node chains, and that's stage 4 cancer when we have that metastatic disease. So that's how we use the staging to tell us about the curability of a cancer and where it's traveled to.
And my last question to you also about stages is how do those treatment approaches differ from, between early stage and advanced stage cancers, and how does it affect the length or intensity of treatment?
So ideally, if you come to see me at the cancer center, your cancer is already gone. You've already met a surgeon, you've already had your surgery for your cancer, and now I'm just helping you try and avoid it from coming back. But definitely when the stage is more advanced, so when there are lymph nodes involved, or if unfortunately it's traveled to other organs, then the surgeons probably said, well, I can't do anything to help you. And then you come and see me and we talk about lifelong treatments, sometimes with chemotherapy, sometimes with endocrine or hormonal treatments, and sometimes now with immune therapies that are very new and have helped a lot of people with stage 4 cancer.
Wow, thank you so much, Dr. Malkowski. That's very helpful. My next question is for Sarah. If you would kindly walk us through a typical patient journey from screening to first symptoms to diagnosis, treatment and follow-up care, and detail some of the support that patients and families might navigate, as well as when patients typically feel the most overwhelmed.
Okay, I think anyone on this panel could probably answer some of those questions. So I'll take a more broad system kind of approach. I think some of it you heard from Dr. Pert's experience about going through all the different steps and stages. We've talked a lot about the screening programs and how you will move through a screening program. And some of the steps, like we heard this morning from Barb, is like if there's something unusual, then you might be brought back to a screening program. And then after that, it will take you on to further steps. And a biopsy can be done sometimes right at a screening program. So at the breast center, they can do a biopsy right there on the spot with using the mammography equipment. But in other instances, you need to get referred to another specialist to be able to do further diagnosis if a biopsy can be done. And then once there is a positive report that comes back from the lab saying, yes, this is cancer, that's generally when we get referrals into the cancer center. So we really are at a place, as Dr. Mikulski said, that we don't generally start to see patients in the cancer center until we actually have a proof of diagnosis. It can be challenging at times in that diagnostic phase, and that's what we hear very often. And I was having some conversations with people at the break about, I think to the point about when can some of the most stressful times, that part where you're not sure what's going on and you don't have a diagnosis or you're waiting for a diagnosis can be very, very challenging, especially when you do some testing and it comes back inconclusive. And so now you're going to more testing and other things to try and figure out what's going on. A lot of that sort of phase sits with our specialists in the region, your family physicians, and it's a challenging time, I will admit for sure, because it's referrals to different people and waiting for those referrals to come through. So that sort of phase is a lot of from your family doctor, who is the person that's kind of quarterbacking it all as your referrals go out and come back and to try and figure out what the diagnosis is. But once that diagnosis does come through, then it's over to the cancer center, and we have a standard that we try and get everybody in 2 weeks to see Dr. Mikulski or one of the other oncologists in the cancer center. There are sometimes people come to the cancer center, those directly from the ER. So they may show up for something that they're not sure what's going on, and they do a series of tests and discover within a very short period of time that they're dealing with cancer, and then a referral is coming right from the hospital over to the cancer center. So I just want to highlight that that is sometimes how things actually also come through to the cancer center. And the last thing I'll mention for that phase is that sometimes it's incidental. Like someone's going in to have something else done, and they're doing some testing to get ready for that test, or to just get some information about what's going on with them, and they discover incidentally that there is cancer with that patient. So that, again, whoever is ordered that test generally will be the person to refer to the cancer center. And then from there, and I think Dr. McCullough would probably talk about this in further questions, you have a consultation with the physicians, you start seeing the nurses, and that's where the supports really kick in at the cancer center, is that we have nursing, we have our physicians, we have social workers, we have dietitians, all folks who are participating in those appointments to help you get to treatment, including sometimes that financial barrier. Right? If there is like a concern about the cost of the medication, it's not covered for some reason, we have folks called drug access facilitators who do a lot of work to try and figure out how to get that coverage so that that's not a barrier for people to get to treatment. And the last thing I'll just mention in terms of navigation, there are some instances where we have supports for navigation through all of this. And it's not universal, which is, something I would love to see in the future, that we have some way to universally have somebody there that can navigate people. But in terms of marginalized groups in the province, one of the groups that has been identified as being marginalized and very challenged with accessing healthcare is in the Indigenous population. I think some people may not realize, but in our region, we do have quite a few Indigenous folks and a large community, over 13,000 for sure, just in our cities. And so in the province, knowing what came out with the Truth and Reconciliation, it was identified that Indigenous people need to have access to navigation. So at the Cancer Center, we actually have an Indigenous nurse. She is a nurse, but it can really be in any discipline, but we have an Indigenous cancer navigator. And her full-time job is to support patients right from screening all the way to palliation. So in those instances, for folks who are really having challenges getting to screening or getting to appointments or whatever, she actually goes with the patients to all of those steps along the way to try and help make sure that people can access the care that they need. So that's another sort of just layer that we have in the region to support.
Awesome. It's so impressive to have that many supports with it. Now I'd love to hear from Dr. Kurtz about a little bit more about your experience. If you would kindly share how you felt when you first received the diagnosis, and share a little bit about what helped you move forward and what you wish you'd known earlier about cancer or screening or things like that.
So what I felt when I was first diagnosed was really shock and disbelief. I think that is a sentiment that is not unique to me. I think a lot of people probably experience that. In terms of what I wish I'd known about screening, about my first diagnosis, I think one of the things was I needed to do my breast screening, so the self-breast examination. But one of the things I don't think that was hit home as much was the fact that it's not just about feeling and the palpable touch that you can feel a lump. There are also changes like discharge or things like that should be things that you should be concerned about. Other things you can be concerned about, it's the change in the shape of how your breast looks. So if it's becoming more dimpled or something odd about it. Or other things like if you have a rash on your breast that is not going away, those are things that you should also be concerned about. It's not just about feeling it and feeling for a lump, it's also about the behavior of your anatomy and how it's changing.
Thank you. Thank you for sharing a little bit of your story with us. Now a little bit more onto the cancer treatment journey. This question is for Dr. Malkowski. Could you walk us through the typical cancer treatment journey from diagnosis through treatment and follow-up care? Specifically looking at the key members of the care team, care coordination, and how families and friends support loved ones.
Sure. So, the diagnosis of the cancer is actually, as I mentioned, well before you come to the cancer center. So really, the journey starts at the screening program with your family doctor, ordering tests, and then a biopsy of some sort. So getting some sort of tissue to confirm that you have this cancer. And then usually the next step is meeting with a surgeon for hopefully an early stage cancer to have surgery. And all of those things are actually pretty much almost always outside of the cancer center. There is a special lung cancer clinic at the cancer center where the lung surgeons meet you there. And at the Waterloo Wellington breast center, the surgeons go there themselves, the breast surgeons. But everyone else, in terms of surgeons, they're sort of scattered in the community, or they're in Guelph or Fergus or Mount Forest as well. After your surgery, sometimes it's such an early stage cancer that you don't even need to come to the cancer center. You can just, meet with your surgeon every few months or once a year and everything's fine. But if there's a worry about the cancer coming back, then there's a team of us at the cancer center consisting of myself, like an oncologist, a radiation doctor, a radiation oncologist, and then there's also our palliative care physicians who help with pain and symptom management. And all of us work together at the cancer center to sort of guide you through this new journey, which is very scary. It was terrible during COVID when, our visits were limited, you couldn't bring in your family. But now you can have support with your family with you. The chemo journey is all supported. You have the ability to bring your family with you. And as Sarah had mentioned, there's a lot of help available at the cancer center with our nurses, dietitians, or social workers. Pharmacists are really important because a lot of questions we have about drugs, they always have the answer. And all of the volunteers too at our cancer center. So it's a very busy place, but with a lot of support for everyone that is scared when they come in through the doors.
And how can your families and friends support loved ones through treatment?
So sometimes a lot of the emphasis is on food and feeding their loved ones, and sometimes that's something that loved ones, the last thing that patients want is to be overfed. But so really, support is more, I think, about helping patients feel as normal through their journey as possible. Sometimes they're trying to make life as normal as possible. Sometimes it means planning that trip that you always put off because of work. Like sometimes the focus shifts now to what is really important in your life, and maybe stepping away from your job a bit if you are able to, which sometimes is not possible, especially when your family is relying on you for support. And that's been an issue with some of our immigrant populations that come here to support their families, then have to face a cancer diagnosis and go through all this treatment and really not be able to afford to take off work. So, but that's, it's very individualized how everyone goes through it. And we have resources through Hope Spring, as you saw outside, and this wonderful institution that to try to bring a silver lining to some of the treatment journey.
Great, thank you. So talking a little bit more about supporting patients during treatment, and I'll just add, if you have any questions, make sure you're adding them onto your cue cards, and I'll send volunteers around to collect them in a bit. But my next question is for Susan. So Susan, from a patient's point of view, how would you describe the cancer journey? What are those overwhelming moments that patients most commonly experience, and how do oncology nurses help patients feel supported throughout the process?
Yeah, so thanks for having me. And I'll admit, when Ernest approached me about a year ago about this, I didn't realize I'd be up and speaking in front of everybody, but I'm going to do my best to hit the key points. And I will share that I see amongst the audience a lot of my colleagues. Thank you for coming. Thanks for supporting and listening. And I think this is a really, really important work that Ernest has started, and it's good to see and good to be a part of. So I think, from the patient's point of view, and how would you describe that cancer journey? I think, there's a lot of points that Dr. Natoya Pert made that are very relevant. It's very individual, and I don't think there's a one-dimensional answer to this question. I think each and every patient has their own unique journey. It starts at the time of their cancer diagnosis. It carries through whether or not they need treatment, what that treatment looks like, and after treatment, whether that's survivorship or, of course, the reality of the unfortunate truth that one could succumb to their disease. I think the hope is that this early screening push is helpful in avoiding that kind of circumstance, and this work is so important for that. We can highlight the fact that the different ways in which someone can receive their diagnosis is variable. It can be simply someone going to their family doctor and having routine blood work done, and maybe something on their complete blood count was a little bit off. Maybe they're a bit anemic. Maybe their platelets were a little bit low. We haven't talked about the many other types of cancers that are out there. There's hematological cancers, and we have a hematology oncology group that works separately from the medical oncology. We've got actually a nurse here, Angelina, who's one of our key nurse practitioners in managing lymphoma patients and their journeys at our center. So it's very important to realize that everyone's journey is different based on the type of cancer that they have, the way in which they were diagnosed. Like I said, it could be just routine blood work. You feel fine. You don't even know you have it. And you could have a very serious blood condition. Or you could be someone who actually makes a trip to the emergency department because you've had uncontrollable pain that isn't making sense, or something else, a fever, and you go to the emergency department and you have tests that show that there's obstruction or this or that, and further tests go on. So like I said, it's different for everybody, and it's really important as a nurse and as a team to understand those differences and treat the person as an individual, taking into account that some may come in and just need monitoring for years with us. That's not uncommon either. Stage 0 CLL, hematological cancer, doesn't need treatment. It needs monitoring, and the physicians, the oncologists, they're experts in understanding when is the right time to put someone on treatment, and when is the right time to just continue to monitor, because treatments have side effects. Treatments have toxicities to different other areas of the body. There's toxicities we need to be mindful of, and these all are taken into account, and it speaks to my point that the journey is so tailored to each person and what they have and what they're going through. It has been already covered here today that one of the most overwhelming moments that patients commonly experience is your follow-up question. I'm just going to lead into it. And for me as a experienced oncology nurse, that's also important to recognize that that's different for everybody. But a common theme that I see in my career is it is that waiting. It's knowing something's wrong but not having the answer yet. Knowing something's wrong, but your test isn't for a couple of weeks. The test happens, and now you have to wait again because it's not going to be reported for some time. So those waiting periods are often the most stressful times for patients and their families to get through. We understand that, and it's not infrequent for our patients to be calling into our center looking for those answers and knowing that the kind of stress that that's causing is very real, and helping support through that. So that is what I would say is probably one of the more overwhelming moments. And I'm speaking from an oncology nurse working at the center for over 20 years, but I'm also speaking personally. I started my career in oncology with one person in my family who had breast cancer, my mom. Since my time as a nurse, my dad's had cancer, my sister's had cancer, my grandmother has had cancer, my grandfather has had cancer. So, I come into this field with a mom that had DCIS. Okay, so we've heard about that a couple times today, and she's alive and well today at 80, planning her 80th birthday party in a couple of weeks. So, wonderful news. She's a testament to, catching a diagnosis early. Okay, so that was screening, age 50. That was her date. So, fortunately, she happened to have that at the time that the screening was for age 50. At that time, this was back in the 90s, right? So, when I'm talking about these experiences, just know that I'm speaking from a family member. I'm speaking from personal experiences as well as my professional experience in dealing with many, many families and patients that have gone through this journey.
I feel like that really connects to what we talked about this morning about how it's more than the data, it's the stories and actually people behind this.
Yeah.
So, I'd love to know more about how oncology nurses such as yourself help guide patients through what is, fairly complex healthcare system.
Definitely, yeah. So, again, there's usually an event that leads to the diagnosis. This varies. Diagnostic tests are completed. There's an official diagnosis of cancer. This leads to the referral at the cancer center. Once appointments have been confirmed with the patient, our intake process begins. So, how we have set up our patients is and their visits is that we actually, due to the pandemic, there's a few things that changed, and some was definitely for the good and for the better in terms of prepping a patient to come to their appointment. So we adopted and maintained the virtual aspect of some of the appointment, meaning that once a patient has confirmation of a consult appointment with one of our oncologists, one of our clinic nurses makes a phone call to that patient after our new patient referral process has been completed, and we start collecting the information we require to see the patient in consult. This is really important because it sets up that appointment with all their prior history, the diagnosis, the surgeries, the medication lists, other health problems. What are we dealing with in terms of the whole person, so that when they come into the center to meet with the oncologist, say Andrea and her team, they've got all that information ready to go. We don't have to take that 20 to 30 minutes of that appointment. We've already got it. We're set up to know, and oftentimes the physicians can be planning before the patient even arrives. And set someone up for success in terms of, do they need additional tests? Do we need to do some genetic testing to determine whether it's this treatment or that treatment? I don't think a lot of the general population realize that one type of cancer can be treated different ways based on genetics, based on DNA sampling. So these are very specialized tests, and that can sometimes be set up ahead of time as well. So we're also actively working on programs for that at our center to be more timely. We're a lot of times it's recognized that it needs to be done, but is there a way that we can do this ahead of time to be even more in prep for something to go forward, right? So this speaks to like having that window of prompt treatment. once the consult occurs, this is where the healthcare team, the physician, shares the diagnosis. What does the diagnosis mean? What staging is it at? What can we expect? What treatments can we offer? What kind of response rates? What kind of overall survival rates? All the information the patient, the family needs to actually make a decision and be feel like they're educated to make that decision. Not everybody chooses the same treatments depending on what's going on in their environment. So, but having all those facts presented to you that you can make an informed decision is very important. So consent is then collected at that time and the journey begins from there. And that can vary as well. Journeys can be a pill, taking a pill every day at home. Sometimes it involves being admitted to the hospital inpatient oncology unit for weeks at a time. It depends on the disease, the diagnosis, and what the treatment is. Sometimes it involves having extra devices put in to help with either drainage from, a stent. It can be a portacath, a PICC line. It could be just an IV, but these are all things that could be part of the treatment and vary across the population depending on what it is. All these things are, there's, in respect to treatment, there's literally hundreds of different types of treatments, including oral agents, as Andrea had suggested, would be hormone manipulating drugs, chemotherapy, immunotherapy, immunomodulating therapies, radiation, and then all the supportive medications that could be required in addition to these. So I could speak for literally hours about a lot of all this. So I'm trying to stick to key points here, but as you can gather from me pretty much going on a rogue pattern here, there's a lot of information, and this stuff is catered to each person individually and reviewed at that appointment, and then a plan starts. And I can generally say that when patients know what they're dealing with and they get that education, I think most people feel that when they're in action and they know what they're dealing with, the anxiety does settle a bit. For most people, it's not to say that there isn't residual anxiety and fear associated with the journey, but patient education is just so important, and we use it literally at every visit, so throughout the center. Oncology nurses help patients feel supported in many, many ways. We have a very robust patient education library that we use. When we're providing patient education, it's extremely important to understand the global environment of the patient, meaning what family, what friends do they have for support, what's their emotional capacity, what's their mental capacity, what's their physical capacity to engage in this type of education. These things all need to be considered because sometimes the patient needs that other support network to be able to retain this type of information. And so these are all things that our skilled nurses are used to assessing at these appointments and applying what's necessary or what's most suitable for each person.
I was going to ask about how oncology has a support, but you beat me right to that. So thank you so much for sharing that information.
No problem.
My next question is about the patient experience. It's for Dr. Natoya, for you. My question is, what role did family, faith, or community play in your healing journey? And what advice do you have for caregivers and family?
That's a really good question. I would say that it played a huge role. Why? Because of the fact that when I was dealing with my diagnosis, both the first and the second time, it required a lot of me relearning that I couldn't do it all on my own. There were things that I definitely needed help with. And so I had to rely on friends and family and the support system to help me get through that. I would say advice for during this process would be patience with the family member who is being diagnosed, but also patience with yourself. And also, I strongly advocate for everyone within who's dealing with that at that point to get external assistance if they feel that it is necessary, because we cannot do it on our own. For my personal experience, when I was diagnosed the second time, the recurrence, I was very frustrated with the fact that it happened again. And one of the things that I struggled with and wanted more of was a community that understood what I was going through. So a community that understood recurrence. And so I had to find other sources that were not within my network, because I didn't have any surviving colleagues or friends or relatives who had dealt with the recurrence, so that I needed help to navigate. The other thing I can talk about from the perspective of being the child of a person who had breast cancer and then had a recurrence was that while I was going through that process and dealing with my mom's illness, a lot of the things as a child I had internalized, and it's important that I should have been voicing a lot of the frustrations and the fears that I was feeling rather than bottling them up. And later on, it was also important that we continue talking about it, because it can have an impact on the child's development. Children do observe a lot and they retain a lot, and so it's important that we also support them during this process. So that's from the perspective of the child, and then from the perspective of the adult, I would say the patient going through that has to also learn to just rely on their support system again, and also realize that or appreciate that sometimes it's going to be difficult, and so sometimes it's just going to be tough. It's going to be tough. So I think that's the best way I can put it. It's going to be tough.
Yeah, it sounds like it. Thank you for sharing that. Speaking of some of those common challenges and barriers, my next question is for Dr. Mikulski. What are some of the common barriers that delay parent patients from starting completing treatment, such as financial concerns, transportation, caregiving, those sort of impacts, and what supports exist for patients to overcome these barriers in the region?
I think that's a really broad topic, but just addressing the room today, I think it would be best illustrated by an example that sort of shows some of the barriers that exist, and for some of our patients especially. So for example, I met in the fall a lovely young woman who is here on a student visa studying at our local college in order to become a practitioner in a field of health, with the hope of getting her permanent residency and staying in Canada and bringing her family here eventually. So she is here on her own. So that's a big barrier, is being isolated from the people that are back home or your loved ones. She doesn't have much money. She's working on the side while she studies to try and support herself, and maybe even send money back home. And she's very focused on that and very determined. Now, unfortunately, there's a new diagnosis of breast cancer, and she went to the student health center at the college, got a referral to the breast center, was diagnosed with a biopsy. But the surgeon was worried about the size of the breast cancer and some of the characteristics of the breast cancer. So before having surgery, was sent to see us at the cancer center to discuss whether she might need chemotherapy. When she comes to the cancer center, it becomes really sort of obvious after doing a CT scan and a bone scan, which are ways to look for cancer in other organs like bones and liver and lungs. It becomes obvious from those scans that unfortunately the cancer is already spread. So this is not a curable breast cancer anymore. This is stage 4 breast cancer. So I have this young woman in front of me who, it's like taking the time off from her work and has school the next day, and practical stuff too with that schooling. that's seeing me and I have to tell her this bad news. And obviously, all of her family's back home and she's, she's from a sub-Saharan African country, I guess, without going into too specifics, but I tell her, this might be a time where you might consider, maybe going back home, and these are the names of the drugs that I want to give you and stuff, and see, what resources do you have back home? And she comes back the next week and says, there's no resources back home, and I want to stay here, complete my studies, bring my family here, and continue to work and do everything else I was doing normally. So, we got started on treatment, and financially, it's a big barrier. If she didn't have insurance, but she doesn't have an OHIP number. So luckily, she has insurance through the college that she's enrolled in. So, everything goes through insurance. So there's a lot of paperwork involved in that. That's different from what we see when just anybody that's a resident here comes through. But that financial aspect is huge. And then we try to help her by working around her schedule for school so that she can stay in school, maintain her status here, and hopefully even get a job and get residency and get an OHIP number here. So that's the kind of stuff that our social workers help us with, our pharmacists help us because we get, we can get drugs that are subsidized. Our chemo suite, like all these administrators and nurses have to cost out what the chemotherapy costs. We don't even think about that when we're all under the same OHIP umbrella. But if you're coming here with student insurance, that's a really big factor. So the types, and she's still here alone. Her family can't afford to come here. She's, hopefully has some social supports. There's Hope Spring. There are ways to connect through programs that hopefully she's taking advantage of, but she's almost too busy with all of her treatment and studying and working. And, these are the kind of resilient people that are getting through, that we've seen so many illustrations today of this. But it's how, that's why we do this to help people get through. And hopefully there's a better life at the end of the day. Her cancer is controllable for a long time, hopefully. And that's what we strive to do at the Cancer Center.
I really hope that answers all. Really do. Thank you so much for sharing, Dr. Bukowski. That actually brings us really great to our next section, where I'll invite Uma to come and speak a little bit about equity in cancer care. So we're especially curious to learn about how REN, or the Regional Health Network, is addressing inequities in cancer care, particularly for racialized immigrant and ethnically serving communities, and if there are any specific programs or initiatives that make care more accessible or culturally responsive.
Great. Good afternoon, everyone. Thank you, Dr. Osai, for having me. And full disclosure, Alera and I, we work together in diversity, equity, and inclusion. So just wanted to put that out there. Okay, so CancerCare here is delivered through the Regional Cancer Center, and many of the people working here, they're employees of REN. So from a DEI and a health equity work perspective, we're actually helping make that care more accessible, more respectful, and more responsive to the communities we serve. When I had come to the hospital in 2021, there was no DEI program. There was nothing. We basically had to start from scratch. But since that time, the hospital has adopted a health equity framework from which we operate, and this sort of drives much of the work that we do in terms of answering that question. So what the health equity framework does, it prioritizes health equity. It prioritizes culturally safe and trauma-informed care. It prioritizes gender-affirming care. And accessibility, and a lot of the work that we do is on consultation with many of the departments that we need to bring health equity forward. So what that looks like. So a huge part of our work is education. We do inclusive leadership education or workshops with all the leaders in our hospital, like 200 plus. What that does, it teaches them what does that mean to be inclusive, what are the traits of an inclusive leader, and how those decisions actually show up in the work that they do. And that might involve unconscious bias workshops. So they understand when some of their decisions may be biased, when they don't have all the information, and basically telling them how to pause and ask, well, who am I missing here? Who have I not consulted? And what does that mean? We also bring information about health disparities for certain marginalized groups. The Black community, the Indigenous community, we bring that information in our healthcare. And we basically talk about the importance of DEI and allyship in healthcare. And the goal of that is to create an inclusive environment for both our healthcare workers, our employees, but also our patients. And by doing that and creating those conditions, it actually helps improve the health outcomes so that people don't feel uncomfortable when they come to the hospital. They will actually return if they need to get treatment. And that goes a long way. We've also, not only do we do those workshops, we also have online modules for staff. So once again, importance of DEI and allyship in healthcare, understanding unconscious bias, developing cultural intelligence. So we're in a region where there is quite a bit of diversity. Our patients are diverse, our workforce is diverse. So what does that mean for people who are working here? What does it mean for workforce inclusion, and what does it mean for patient inclusion? Developing that cultural intelligence and not making assumptions about the people that come to the hospital. And really pausing to ask what is important to you that would help make your care better. So that's some of the work that we do. We're of course, it was already talked about, making the information that we provide accessible through various languages and also making it understandable. I think Dr. Davies talked about certain language and people don't understand, especially people coming from many different countries. So making it the language simple so that people can understand what it is. We've recently started to do some socio-demographic data collection. I think one physician talked about us not collecting race-based data. So this is something where we've piloted in a few areas of the hospital. So we're actually rolling it out in the hospital now, asking people what's their ethnicity, what's their language, gender identity, Laura, what else we ask?
There's income, there will be housing status.
Yeah, so it's really important to collect that data because then we're going to know, well, what is the experience of those people coming to the hospital? Who's not coming to the hospital, and maybe what outreach we need to do, etc. So all that work certainly is going to help us in making our services more accessible to marginalized communities. And another thing that I wanted to talk about is increasing the diversity of our staff. And I think it was mentioned already, it's really important that we have diverse staff because it helps patients, who may be coming from different countries where the healthcare system is different. It's a way to help those patients navigate the healthcare system. So a lot of the work we do is about making sure that our recruitment is inclusive and it's free from bias, adjusting our policies so that the best candidate is hired for the position and there isn't any racism or discrimination in how we recruit and select people. So with regard to that, I said we did our health equity framework. The hospital, we've merged. It was Grand River and St. Mary's, so now we've merged and we're now called Waterloo Regional Health Network, and a strategic plan has been developed. Now there is an underlying principle in all the activities in that strategic plan where health equity is a part of it. So it's something that it's a principle that everyone has to follow, and and hopefully we're gonna continue on our journey towards helping marginalized communities access healthcare.
Yeah, for context, Uma is the manager of DEIB at Diversity, Equity, Inclusion, and Belonging at the Waterloo Regional Health Network. So she is well positioned to speak to some of these initiatives that she's speaking to right now. But I'm also very curious, how does REN collaborate with community partners to support cancer patients holistically? And are there any specific community-based programs that help newcomers and marginalized patients access cancer care and follow-up support?
Yeah, so we, here I'm just getting to my notes here. We actually do partner a lot with community organizations. We work very closely with member partners of the KW4 OHT, and I see Maritza over there from Public Health. So we try to collaborate as much as possible because we recognize that we can't impact health equity for marginalized groups alone as a hospital. Like, we have to work across the system. And it's really important that we work with community organizations to see where we can partner. So one example is that any sort of the modules that we develop at the hospital and the workshops we develop, we offer it to those community partners or those healthcare partners so that we can spread the knowledge, and also if there are particular initiatives, it's really important. There was a lot of consultation when we were developing the strategic plan for REN, and community had a lot to say, and they basically said that they are very interested in it's really important to partner. So in terms of partnering with communities, I can give you a few examples. So one of the things that we're going to be doing, and we recently announced this, is we're going to have a series of culturally safe. It's a learning series for our staff. And what we're going to target is the various religions, because when people are sick and they come to the hospital, religion is a key part and their faith is important to them. So in order to help them, to really enable that and for staff to understand how important it is, we're going to be partnering with community on what those workshops look like. What is important to specific communities, and also develop some sort of resource for our staff. One of the things we worked with community was we developed a Muslim patient handbook, which talked about all the things throughout all aspects of care, but from birth, what might be a spiritual practice that's important to them. And the idea is for our staff to be aware of it and to not be shocked when a patient asks them, I'd like to do this. At least they can have some inkling like this is important, so they can try and facilitate. Same again, we talked about the importance of prayer for the Muslim community, how it's one of the requirements is that they need to pray 5 times a day. So the importance of directing them to a place where that can happen, the importance of washing, wudu, so when the patient says that to the caregiver, they're aware of it, or they recognize that it's important to the hospital that we try to accommodate our patients. So we're doing the sessions, there's 7 sessions for the year in all the various religions. So we're going to be partnering with community to understand what does that session look like, and then also what's the resource that we're going to give to staff. So that's one example. The same thing with the Indigenous community, the importance of smudging for them. And doing ceremonies. So at the hospital, we do a sacred fire every season. And that's a way for staff to learn about the Indigenous community and what's important to them, and ceremony. Another thing we're going to be working on, and both Alera and I, we've started, is we're going to be working on a Black health plan. And we can't do that. We need to have community involvement in that. So that is another thing that we're going to be doing.
earlier. And I mean, you've already spoken to some of the tenets of this, but what does belonging mean in cancer care and why is it important for patients and families?
Yeah, belonging is really, really important to me and I guess to everyone. And it's to me, belonging means a patient can come into care and they can still feel like themselves. They can feel respected and heard, seen, heard, and feel like they matter. And they don't have to fight to be recognized for a certain aspect of their identity. So for, as I said before, like a Muslim patient, it might mean, giving them the ability to pray, or having a space for them, or having prayer mats for them. It can mean, for a transgender or gender diverse patient, being addressed by their pronouns or their chosen name. That's one of the things that we recently implemented, where we're able to capture that now in the healthcare system. The health record. And in terms of diet, like having kosher or halal meals for them, and like smudging for Indigenous patients. Being able to accommodate these things for diverse groups of people can communicate to patients that they belong. And when you're sick, that's one less thing to worry about. If that is something that's important to them, it's one less thing to worry about. So that's really what it means.
Absolutely. Yeah. Thank you so much for answering those questions. My last question now will go to Dr. Malkowski. And we're curious, are there certain cancers or patterns of diagnosis seen more often among Black and immigrant populations? And if so, why do these disparities exist and how can people help eliminate them? Really a question.
So I think part of that was addressed this morning in Dr. ACCE's talk a little bit, but we do have quite a lot of population data and outcome data that shows us that probably due to genetics, really, we see more, for example, triple negative breast cancer in women from the western coast of sub-Saharan Africa. Don't really understand why. I think the genetics are a bit controversial. We have about 22 genes that are responsible for breast cancer, but there's also combinations of genes and environmental factors that play a role in the development of breast cancers as well. We know that in Black men, prostate cancer is much more prevalent. And there is no real screening for prostate cancer that is a population-based screen, so we don't have Ontario-sponsored initiatives for prostate cancer, but there is a way to check for prostate cancer, which is to measure something in your blood called PSA. And unfortunately, right now it's a shared decision between a provider and a patient, and you have to pay for that test because we just don't have, on a population level, evidence that finding prostate cancer early actually changes outcomes. It's usually a very slow growing cancer. In our immigrant population, we do see from Southeast Asia, especially gastric cancer is more prevalent there. So, especially first generation immigrants that ate a diet there come here, and then there are higher incidence of gastric cancer. And then there's some liver cancer, and that is associated with hepatitis C and B that's endemic more in some countries as well. We have a very, in terms of addressing, when we have to recognize these people are from, or have these risks, and I think it all comes down to early detection again, because once it's detected, then treatment is very standardized, and hopefully everyone gets the same sort of access to treatment here at the Cancer Center, at least I hope.
That's what we hope, yeah. Thank you so much, Dr. McCloskey. We'll now move to the question and answer period, and I'll ask you to say up that this might be a question for you. It was recently announced in the USA that there's a pre-screening cancer test that provides early detection risks are we aware of this pre-screening test, or is there a pre-screening tool similar to that available in Canada?
Yeah, so I think they're talking about Galeria. It's a company in the US that basically looks for DNA in your blood that may be the DNA actually belongs to a cancer that you might harbor that you don't know. And they're looking for changes in the DNA called methylation. So, cancer becomes cancer because something in your body mutated. So a cell became abnormal, and usually that can be linked to some DNA changes. And DNA has these methyl groups on it. And sometimes in cancer, or a lot of times in cancer, the number of methyl groups on the DNA can change. So that test in the US is looking for changes in methylation that may actually show that you have a cancer, and it's not cancer specific, it's cancer agnostic, which means it doesn't necessarily tell you what cancer you have. And they've done some trials, but I don't think they've been very good at showing that it's a good screening test. That's the problem. It's very expensive. It hasn't been shown to probably change outcomes. And then once you have the test and pay for it, then you're responsible to figure out what to do with the results. The same can be said for whole body MRI screening. I mean, I haven't met anyone yet at the Cancer Center who came through because they had a whole body MRI, but now that's available in Buffalo and in Vancouver through private company where you have to pay, and you can actually, the amount you pay, they'll screen for like different body parts. But the problem is once you have that test, there's a lot of false positives. There's a lot of things that could be abnormal, and Dr. Walls can speak to this, that end up being nothing. So like MRIs are great at seeing all sorts of things, but maybe none of them are cancer. So these are very controversial topics, and have not really shown to, at least in my experience, anecdotally, has not shown a difference to the people that I see, because it's taken us decades to reach the tests that we have for screening. And I think as long as you pay attention to symptoms and do screening, you have the best chance of finding things that can make a difference.
No, thank you for answering that. And a last question, the FIT test cannot detect, the stool test that you take cannot detect polyps. So when should a colonoscopy be done? Should a baseline test be done after age 50?
Well, that's also a bit of a controversial question. If there's symptoms, then it's not really a screening colonoscopy. So symptoms of weight change in bowel habits, bleeding, definitely you need a colonoscopy. That's not even a screening colonoscopy. You should be, that is a diagnostic colonoscopy to make sure you don't have a pathology. There are people that are at high risk of colon cancer, and now screening actually is going to move to age 40 in the near future, I believe, because that's where all the other provinces are headed. So if you're at high risk of colon cancer right now, the screening starts age 50, that will move down. It should be about, should be probably age 40, because the incidence of colon cancer is unfortunately rising in young people. And I can, can't tell you how many new young people I meet who have colon cancer.
Seems to be on the rise. Well, that actually concludes our question period, but Dr. Malkowski, I'll ask you to start us off on that. I'm going to ask each panelist to share 1 or 2 sentences on a key takeaway. So Dr. Malkowski, do you have 1 or 2 sentences or advice regarding screening and treatment?
I think for screening, it's, definitely don't be afraid of vaccines like that we have for HPV, for example, that help prevent cervical cancer and head and neck cancers. And then for treatment, I feel like if someone's telling you to pay for something because that's going to help you, sometimes you have to be careful what the motivations of people are. So I see a lot of patients that travel elsewhere or seek out novel therapies, but they also have to pay a lot of money for those therapies. And I feel that sometimes they, I sort of would caution them about motivations of some of the places that they visit.
Thank you. And Susan, I'll ask you to come up if there are 1 or 2 sentences about navigating the cancer journey with 2 pieces of advice, 1 or 2.
Yeah, so if I'll speak from like the lens of the oncology nurse, and so that really encompasses the patient that is at our center receiving treatment. And for that population, it's really journal your questions, participate in the education materials that your team is providing you. These materials are key to access to other resources, knowing when to call in, listening to symptoms, getting early treatment for symptoms while you're on treatment, who to call, and if there's questions that you don't have answers to based on these materials, your oncology nurse is a call away. Those questions can be directed through our call center, and they know where to find the answer for you. So really paying attention to the materials and the education that you're being provided. They are the experts in guiding patients throughout their treatment, in terms of knowing what to take, what to do, what not to do when you're going through these types of treatments, the limitations and the safety mechanisms that need to be followed to ensure that you're safe and that you're looked after during your treatment.
Great, thank you. And Sarah, I'll ask you some other question. Your last advice about navigating the cancer care system.
I think we've heard today can be complicated at times and tough. We do rely a lot on our primary care providers to be the first place to help direct some of that care and for advocating for when something doesn't seem right. So if you don't have a primary care, if you don't have a family physician, I hope you had a chance to visit the table and learn about how to get yourself lined up. But we, as I said, we have patients who come through drop-in clinics and through events, right? We're going to be doing a mammothon next month, which is focused on priority neighborhood and a chance to say, hey, you want to show up at the breast center without an appointment and have a mammogram? Let's do it. So there are various ways you can access, even if you don't have a family doctor. So seek those out, take the information, and follow through on those opportunities. I know we've talked a lot about the challenges and some of the scary things that we know about cancer. We're seeing it in younger people, etc. But I also feel like in the course of my 30 years of doing this work, a huge change in cancer care, and the types of treatments we offer are vast now compared to where they were a few decades ago. And the patients are living longer. They're living with their cancer, which is a huge change. And we're really busy at the Cancer Center, and partially it's because we're a growing community and we have a lot more people in this region. We're also busy because people are living longer and they are coming back for ongoing care and many treatments, where in the past we would only be able to offer surgery and 1 or 2 treatments and that's it. And now we have folks who would come back for another cycle of treatment, and now we're going to try this, and now we're going to have another radiation treatment, or we just can manage the care in many different ways and for a really long time. So there's a lot of hope and a lot of advances. So that's what I think I wanted to say about the system. Thanks.
And Dr. Natoya, if we could just get some quick advice from you about what advice you would give to patients who have just been diagnosed with cancer or those who are undergoing treatment.
My first advice would be reach out to your support group, people around you. Dr. Andre's, I'm sorry, I'm going to butcher your surname. I tried, so I won't say it. Dr. Andre's story about the student who is far away from home. It's something that a lot of immigrant communities can resonate with because we're not always with our family. And so I say reach out to family, but that can be challenging, or reach out to your network. That can be challenging when you're in a new place, your network isn't here. And so at that point, it's going to be even harder, which is one of the reasons why where we are, we have to try to make community. We have to make a sense of belonging, a sense of purpose, a sense of place where we can feel at home. And so getting involved with organizations that can be a support system to us during this time.
And last but certainly not least, Uma, if you could give us some advice on equitable care and community support and perhaps belonging, just to wrap us up.
So I would encourage, let us not make assumptions about people, but have a certain curiosity and inquire like what might contribute to someone's belonging. And if there are patients coming to the hospital, I would encourage them to say what might be an aspect of their care that we can support them in, because our staff is probably aware of it and is looking for a way to accommodate your sense of belonging.
Thank you. And if we could just give a last round of applause for our panelists. Thank you for your insight and the time and the effort that you have had. You so clearly put into your work that you do. So thank you again. Next, I will call up the ACCE President and CEO, Dr. Ernest Osei. Please provide some time.
Thank you, everyone. Before I talk about anything, there are a few people that I need to acknowledge here. Look at everyone wearing a white t-shirt. Thank you very much. In particular, Dorothy, if you don't mind standing up, she's the event organizer. My wife is here. She's been taking me to Costco a lot this week. And at the back there, I have two guys sitting down. If you don't mind getting up, they are members of the ACCE board. I also want to acknowledge the International Immigration Research Center, specifically Jenna, Dr. Jenna, Val, KW spoke. I don't see them here. They said they're not good turnout, but they help. And then the KW Immigration Partnership and the Ghana Canadian Association, Percy. Thank you very much. And for our sponsors, I'd like to acknowledge Walmart and Global Donation Management. They donated something to support the work that we are doing. KW4 also donated something to help us. And very thankful to the International Migration Research Center for this place and all the work that they've been doing to support us. Now, on behalf of the Alliance for CancerCare Equity, short ACCE, I want to thank all of you for coming to this special gathering, empowering communities, a cancer awareness and education event. Seeing so many faces here today, community members, healthcare professionals, survivors, and partners remind me of why ACCE exists. Because we believe no one should face cancer alone, and no one should lose their life to cancer simply because of where they live, the language they speak, the color of their skin, or just because of their financial situation. Let me give you our story. Alliance for CancerCare Equity began with a very simple but urgent question. How do we ensure that every person, regardless of background or income or the country they live, has a fair chance of surviving a cancer diagnosis? As many of you know, this is not just a global issue, it is also a local one too. Black Canadians, immigrants, and other minority communities right here in Kitchener-Waterloo, Ontario, and in Ghana face serious barriers when it comes to cancer care. Whether it is the fear of diagnosis, lack of culturally sensitive information, or inability to afford treatment, these challenges lead to delays, late-stage diagnosis, and preventable death. That is why Alliance for CancerCare Equity was created. We are a registered Canadian charity driven by a mission to stand in the gap for patients who otherwise might be left behind. We passionately believe that no individual should lose their life to cancer simply because they lack the financial means to afford treatment. Furthermore, we are committed to ensure that a patient's financial situation never dictates their chances of surviving a cancer diagnosis. In Canada, we've supported individuals struggling to afford unfunded drugs. In Ghana, where many of our hearts are rooted, we have provided direct patient assistance when no other doors were open, seems open. We have provided funds for cancer patients, at least 67 up to date, for their chemo, their radiotherapy, surgery, diagnostic tests, and even transportation costs for patients who could otherwise gone without care. I'll go off script here a little bit. There was a 26-year-old female 2 years ago that one of the doctors in Ghana we deal with called and said, okay, if you can help her. She was diagnosed with ovarian cancer 2 years early and had no treatment for 2 years. The time we went to the hospital, it has metastasized into the lungs and other parts of the body. So I called her on the same day and I said, okay, if you've made payment for your treatment, just go to the cancer center and start your chemotherapy. I called her the following day to see how the treatment went, and she said I wasn't able to go. And I was surprised. So I called her brother and said, okay, why is it that your sister couldn't go? The treatment has been paid. It's about $2,000 for the treatment has been paid. So why wasn't he able to go? What she told me broke my heart. I was going to teach. I walked on the way. He said he couldn't get money for the transportation. So she was going to work, sell things, and get $2 worth. In Ghana, currency was about 50 cedis for the transportation. So I told the brother immediately, I'm sending you the money, let her go now. She went, had the first chemo, came back, I called the following day to check on her, and unfortunately she passed away. That was a broken heart. And that is why ACCE exists. Every patient, every person we have helped, whether here in Kitchener-Waterloo or across the ocean in Ghana, has a name. They have a family, they have a story. And your support has been part of their support, their story. But the truth is, the need is growing. We are here today not only to educate and raise awareness, but also to acknowledge that we cannot do this alone. Alliance for CancerCare Equity is a small organization, but with a big vision. Without consistent funding or ability to help patients, will always be limited. That is why today I am making a heartfelt appeal. If you believe, like we do, that access to cancer care should never depend on someone's income, location, then stand with us, partner with us, fund us, help us reach more patients, educate more communities, and save more lives. To those who have supported Alliance for CancerCare Equity mission so far, our volunteers, our donors, and our community partners, I want to say a sincere thank you. Your generosity, belief in this work are what has made it possible for us to continue what we do. Every dollar anyone has given, every hour anyone has volunteered, every message you have shared has made a difference. In closing, let me say, let this day remind us that cancer doesn't discriminate, but access to care does discriminate. Together, we can change. Together, we can give hope. Thank you to everyone. To help us do it better next time, there are QR codes in front of you for the questionnaire. Please scan and answer those questions to help us do it better. Thank you very much all for coming today and for standing with Alliance for CancerCare.
Thank you, Dr. Asay. Now that you've heard about the impact of this work, we invite you to be part of the solution. Whether as a donor, a volunteer, or a community champion, your support for Alliance for CancerCare Equity can help save lives. Visit our team today. We've got our volunteers at the back and Dr. Asay is here, or you can visit our website, accecan.ca, to learn how you can get involved. Now, as we come to the close of this powerful and inspiring day, let's take a moment to reflect on why we're gathered here on March 28th. Today's event, hosted by ACCE in partnership with the Waterloo Wellington Regional Cancer Program, the KW4 Ontario Health Team, SCOPE, the KW Immigration Partnership Council, the International Migration Research Centre, and the Canadian Association Waterloo Region, is more than a conference. It is a movement. The Alliance for CancerCare Equity exists because we believe one simple truth: where a person lives, the color of their skin, their immigration status, or their income should never determine their chance of surviving cancer. Yet we know that cancer outcomes are not equal. Black communities, racialized populations, newcomers, and underserved groups often face systemic barriers, misinformation, cultural stigma, and limited access to screening and treatment. Too many are diagnosed late. Too many are unaware of available resources. But today, we address that gap. We learned that early detection saves lives. We discussed screening guidelines and how to access them. We explored prevention and modifiable risk factors, how lifestyle, diet, and awareness can reduce risk. We examined the data on cancer in Black and immigrant communities and had honest conversations about myths, stigma, and systemic inequities. We also heard something equally important, that there are pathways to care. There are resources. There are healthcare professionals and community organizations ready to support patients and families through treatment and survivorship. Navigating the Canadian healthcare system can feel overwhelming, but no one has to do it alone. So, what are our key takeaways? First, get screened. Encourage your loved ones to get screened. Second, seek credible information and challenge misinformation. Third, advocate for yourself, for your family, and for your community. And finally, stay connected. The partnerships you see here today are proof that collaboration creates impact. Cancer may not be an equal opportunity disease, but equity and care is something we can build together. Thank you for being part of this movement. So let's continue the conversation, continue the advocacy, and continue working towards a future where everyone has an equal chance at prevention, treatment, and survival. Make sure you interact with our panelists and our speakers, ask questions of them, and to sign up for screening before you go. Make sure you visit the booths outside on your way out, and make sure you complete the survey as well on your way out before you go. Together, we can transform cancer care with compassion and empathy. Thank you again, and safe travels home.